Hello, my name is Nick Sanders, and I'm presenting for my bachelor's capstone project on the implementation of the World Health Organization's Safe Surgery Checklist. The purpose of my capstone project and presentation is to help bring awareness to how we as healthcare workers can help reduce the risks involved in the intraoperative setting. These objectives include why improving surgical safety is needed, how the implementation of the WHO's Safe Surgery Checklist can improve patient outcomes, and what the Safe Surgical Checklist is and how it's used. Surgical errors continue to be a very real problem. Surgeries are one of the primary sources of adverse events in the hospital setting. As many as half of all adverse events were related to surgery, with half of those being considered preventable. As many as 25% of surgeries experience some sort of complication, and this could be anything from a wrong site procedure, surgical site infection, or some sort of injury or even death. Um, at 300, or it's estimated that at a 300-bed hospital, there would be one wrong site, wrong patient procedure annually. And while this doesn't seem like a huge number, it's difficult to track because there's no unifying regulatory body that keeps track of all these. And while the exact number of complications to be difficult to track, there were over 21 million procedures performed in 2014 across hospitals and surgical centers. And with a 25% complication rate, that would mean that there was 5 million complications that year. This definitely indicates that there's some room for improvement there. After implementing the WHO's Safe Surgery Checklist, healthcare facilities across multiple countries saw improved outcomes. Both mortalities and procedure complications were reduced. As you can see, mortalities were reduced by 47 and 62% in two different studies, and complication rates decreased as well. 97% of patients said that the presence of the Safe Surgery Checklist was reassuring to them. This can be one of the scariest or most traumatic days for a lot of people, if you're going in for a big surgery, and anything we can do to help reassure them is important. Additionally, the use of the Safe Surgery Checklist could have helped to avoid 85.3% of wrong site or wrong patient procedures that have happened. So my capstone project was based on the PICO question of, in patients undergoing surgical procedures, how does the implementation of the World Health Organization's Safe Surgery Checklist compare to standard practices affect patient outcomes 1 year following the implementation? So my literature search parameters, I primarily use the electronic database of the SINAL. That's the Cumulative Index to Nursing and Allied Health Literature. Search limitations include English language, research articles, and full text. Key terms included surgery, checklists, outcome, and surgical checklists. Guidelines were developed by the WHO after acknowledging that there was a deficit in patient safety within the surgical setting worldwide. A team of multinational experts was assembled to help tackle this issue, resulting in the release of the Safe Surgery Guidelines in 2009. These guidelines include both an extensive publication as well as a simple safe surgery checklist that was designed to be easy to implement in all ORs and all settings worldwide, but also easy to adjust for those different settings. As part of the guidelines, the WHO recommends the use of a timeout, which is often done by the nurse circulator. So a timeout always takes place before the sedation, and all team members should be involved. They should suspend their current activities. They shouldn't be goofing around with other stuff. They need to be paying attention. It should include 2 patient identifiers, such as name and date of birth, verification of the procedure, site and siter levels, the correct patient position, verification of implants, equipment and imaging, allergies, antibiotics, safety precautions such as fire risk, pertinent patient history and medications, as well as time. All team members should verify that this information was correct after the timeout. So the WHO Safe Surgery Checklist, again, it was designed to be easy to adjust based on the setting. There's not really going to be like a one size fits all. You might add things on or you might take things off depending on the setting, but it can really just be broken down to three, three key stages of the procedure. This includes before anesthesia, before incision, and before the patient exits the operating room. Again, this should have been involved all it should involve all surgical team members. So before anesthesia, the nurse along with the anesthetist, whether they be an anesthesiologist or a CRNA, they should verify that the patient and their name, their procedure and consent. The patient should verify that the procedure is marked correctly, and the anesthetist should verify that the anesthesia machine is functioning and that they have all the necessary medications and that the pulse oximeter is in use and working. The anesthetist should state the allergies, airway risks, and risk of blood loss. So before skin incision, which is kind of the second phase here, involves the nurse, anesthetist, and surgeon primarily. Every team members should help or should make sure to introduce themselves and their roles. It's important for everybody to know who they are or who each other person is and what their role is. They should confirm the patient's name, procedure, and incision site. Antibiotics, if they're needed for this procedure, should be stated as well as when they were given. The surgeon should confirm critical or non-routine steps and the anticipated case length as well as potential blood loss. During this time, the anesthetist should also confirm the patient's specific concerns, such as if there's airway risks again or something to that effect. And the nursing staff will confirm the sterility status of the field, equipment issues or concerns, and they need to ensure that there's the presence of the necessary imaging or implants. So before the patient leaves the operating room, the nurse should verbally confirm the name of the procedure, counts for instruments, sponges and needles, and if a specimen was taken, should verbally verify the name of the specimen and patient. The surgeon, anesthetist, and nurse should discuss any special considerations for the recovery and treatment plan for the patient. And then this video is provided by the WHO. It's kind of a example run of the safe surgical checklist. Again, here it states that it's not going to be applicable to all setting, or it is applicable to all surgical settings, but it's not intended to be comprehensive, and you should be able to adjust based on your needs. This is a surgical safety checklist as provided by the WHO. So before the anesthesia, this is what they'll do here.
Good morning, this is Richard Wright. He's here for a left angle hernia repair. I confirmed his consent is in the chart, and Dr. Gawani came earlier and marked his left angle region. As the anesthesia is technically completed, yes, it has been working fine, and the pulse oximetry is on the patient. Okay. Excellent. Does this patient have a known allergy? No. Does this patient have a difficult airway? No. And do you anticipate a risk of more than half a liter of blood loss? No. Okay. Excellent. I'm in agreement. Let's go.
All right, so that was probably the nerve circulator and the anesthetist talking there. And this is going to...
Okay, everyone, looks like we're all set. So this is the first case today. So if anyone just identify themselves, my name is Tom Elijah. I'm a circulator. So warning, sir. Circulator.
Lauren Spector. Please anesthesia.
And I was saying it's anesthesiologist. Right? Okay, Dr. Wani, can you identify the patient and the site and procedure, please? So this is Richard Wright. This is for a light angle hernia repair. The site marking is showing. Okay, any critical events or steps that you anticipate? No, this is a routine. Angle hernia repair should be under an hour and then we'll come off. Right. Anesthesia problems? No problems. Nothing yet. Great. And Laura, you all set?
I'm all set.
You got your mesh?
I do.
Antibiotics have been given? Grandma's up to 5 minutes ago. Okay, and Dr. Wani, if you need any imaging? No imaging. Okay, I think we're all set. Thank you. so tell them this probably 10% out. Okay. Alrighty, so I have the name of the procedure down as a left inguinal hernia with mesh. That's correct. The instrument and sponge counts due to the needle and sponge counts are correct. From that, I also have a specimen. It's labeled left core lipoma for Richard Wright. That would be correct. Okay. And were there any other problems with equipment or instruments? Critical events or concerns for post-op recovery and management? No, nothing on my. Actually, we should hold this aspirin until tomorrow. We'll creatively make sure that gets into the discharge instructions. So hold that aspirin until tomorrow. Okay. Anything else? I'm here. All set. Okay. Thanks, guys.
All right, there again is the safe surgery checklist, and that concludes the video there. So conclusions that I drew from after reviewing the literature about the implementation of the safe surgery checklist. It's associated with both a decrease in perioperative mortalities and complications. It can significantly reduce wrong site procedures by as much as 85%. The cost of training can easily be recouped through avoiding wrong site procedures as well as complications. And both healthcare workers and patients have a favorable attitude towards the use of the surgical checklist. And here are my references. All right, and that concludes the presentation. I appreciate your time, and thank you.